Good evening, ladies and gentlemen, colleagues. Welcome. Welcome to our sixth inaugural lecture in a series of 7. For those of you who are new to inaugural lectures, I'd like to introduce myself. I'm the Dean of the Faculty, Professor John Fraser, and I like to introduce the ideas of inaugural lectures, and then we are followed by some introductory remarks tonight from distinguished Professor Ian Reid, followed by our inaugural speaker for tonight, Professor Nicola Dalbeth. Inaugural lectures are, in fact, one of the highlights of our academic career. This year we have a record 7 new professors, and as I've said, this is a 6th and a 7. We have Professor Salameri on Thursday evening. They are the highlight of our academic career because they are quite a significant milestone in one's academic career. They are a tradition that dates back a very, very long time. They date back as far as medieval times. In those days, universities were much, much smaller than they are today. They were really just a collection of professors and very little else. In those days, they were an elite brotherhood. They were elected by each other. They were supported by each other and protected. They lived in cloistered surroundings away from the real world, answerable only to themselves and to their esoteric interests, while expecting at the same time to be paid exceptionally well. I'll leave it to you to decide whether things have changed that much. All joking aside, inaugural lectures are a wonderful tradition. They haven't changed for many, many hundreds of years, and they are a way in which universities publicly announce their new professors. They are a means of showcasing our most eminent staff and a celebration of an event that represents, in many cases, the pinnacle of one's academic career. Elevation to the title of professor is not taken lightly. It's a process of selection that is long and torturous. It involves intense scrutiny by international peers who then signal to the university that the individual meets the requirements of an international reputation and an eminent expert in their field, thus giving them the license to say anything they like, thinking that people will believe what they say. They are also a wonderful opportunity for colleagues, family and friends to gather to learn about the journey that has led to academic success, the milestones, decisions, sometimes the heartbreaks, but most importantly the mentors that have helped along the way. And tonight it's my very great pleasure to introduce tonight's inaugural speaker, Professor Nicola Dalbeth, and I shall ask distinguished Professor Ian Reid to provide some introductory remarks. Thank you.
Thank you, John. In addition to welcoming all of you, which John's already done, just to highlight the fact and extend a welcome to Andrew, Nicola's husband, Maisie and Henry, her son and daughter, and to her parents, Pam and Ian. Nicola started life in Kaio. There's possibly people here who haven't been to Kaio. And 3 years later moved on to Rotorua, where probably most of us have been and know where it is. She progressed through her primary and secondary education there, going to Rotorua Girls High School. Somewhere around that time she met Andrew and sometime later married him. The one thing she said I was not to say was that she was a child bride, and I will not say that. I gave her my undertaking. And then at the end of her time at high school moved on to Otago, where she graduated as the top undergraduate 6 years later. One of the many important things that happened during that time was doing a summer studentship with John Highton, which was possibly her first contact with rheumatology, and I think that's just a nice example of how important summer studentships have been to many of us in terms of setting the track for our future career. She then returned to Rotorua and did her first house surgeon year there. There's actually a Dalbeth Road in Rotorua. Now, whether that's testimony to the distinction of Nicola as the house surgeon or to Andrew's forebears, I'm not quite sure, but there's not too many house surgeons who have nodes that they share a name with in a small town such as that. And then she came to Auckland, where she did her house surgeon years. One of her key guide in that time was Peter Black, and he was instrumental in luring Nicola back to Auckland subsequently, and then did some general medicine registrar jobs, again one of her key mentors there being Max Robertson out at Middlemore. and then moved on to rheumatology and worked with the Auckland rheumatologists of the time, Lockie McLean, Nora Lynch, Fiona McQueen being some of the people who guided her at that stage. This brings us through to 2001, which is not very long ago for someone who's becoming a professor tonight. And then she went off to Oxford and subsequently Imperial College in London and worked at the Nuffield Orthopaedic Centre and the Wetherell Institute in Oxford and, as I said, at Imperial College in London. And then I think about 2005 had an important conversation with Peter Black about what should I do with my life, and he encouraged her to come back here. And I think it was about that time that I first heard Nicola's name. She wrote me a letter saying, could she come and work in our group? And I asked a few people about who's this Nicola Dalbeth person. They all said, she's fantastic, you've got to try and get her. But we didn't have any money to support a research fellow, so I sort of did my standard thing and wrote back and said, well, sure, we'll provide you with lab space if you can get some grants to support yourself. And that's seen a lot of people off, and so Nicola wrote to me, I'm not sure how many months later, and said, I've got 3 grants now, is that enough? And that's really been the story of Nicola's life, that she's fantastically energetic and gets things done and makes things happen. And so she's been in Auckland as part of the Bone and Joint Research Group. We had to change the name to accommodate her rheumatological interests, and a spectacular amount has been achieved in that time. I think one of the things she was very strategic about, having worked in inflammatory arthritis in her time in the UK, and that's usually interpreted from a bone person's point of view as being rheumatoid arthritis, Nicola saw that actually gout is a key issue for New Zealand, and Auckland in many ways is the world capital of gout. And so she redirected her studies towards the end of her time in the UK towards gout, and has literally become the world expert on the subject. And so if you go into Expertscape, you will find that the University of Auckland is rated as the top institution in the world for gout research, and that's substantially a tribute to Nicola's work, and she is rated as the world's top individual expert in that particular area, and that's a spectacular achievement in a decade of work. In that decade, she's produced a couple of 100 papers, but she's also worked very hard in a whole lot of other areas. She set up patient groups around gout, and a lot of her gout research has succeeded because she's brought the community that's afflicted by gout on side with her. She's really done more than her fair share of work within the university, serving on groups such as the Ethics Committee, which is a major undertaking, and also contributing a lot to the supervision of undergraduate and postgraduate students. She's also provided leadership in the hospital sector, so she's someone who seems somehow or other able to tick all of these boxes, and incidentally along the way just to have a family, and obviously Andrew's support has been fantastically important in making that happen. So Nicola is an extremely personable, high-achieving colleague. She's a little scary at times in terms of her efficiency and makes the rest of us look a little bit slow, but that's okay. She is a joy and inspiration to work with. As I said before, she's extraordinarily young to be a professor, but it is an accolade that she has earned absolutely in the decade that she's been in Auckland and in the time before that in Oxford. The kudos that comes with this appointment will empower her to continue her upward trajectory in research and in clinical leadership to the benefit of her patients, her students, the university and the hospitals within which she works. So Nicola, congratulations, and I invite you to present your inaugural lecture.
Tēnā koutou katoa. Well, thank you so much to all of you for actually braving this terrible night and coming out. And it's so wonderful to see so many friends, colleagues, family here. So it's really wonderful. Thank you so much. So I'm going to focus my lecture talking about gout, not surprisingly, I think, and really reflect on where we are, where we've come from, and where I hope we will be in future decades. Now, I'd just like to start by describing or explaining this picture, which is a beautiful picture taken by Brigina Poole in our laboratory. And this is a picture under polarizing light microscopy of a tophus. And here we see numerous monosodium urate crystals. And this is really the core lesion that causes gout. And this is the lesion that we really try very hard to manage in our clinical situation. So first of all, I'll just give you a brief outline about what gout actually is, talk about some of the issues around barriers to effective treatment, and then talk about the role of research in defining the impact of disease, the mechanisms of disease, and also the best treatments for people with gout. And finally, I'd like to finish by talking about what I see as hopefully a better future for people with gout. So what is gout, first of all? So gout is a form of arthritis, and it's caused by monosodium urate crystals, these crystals that form in the joint in the presence of high blood uric acid levels. So gout is a really common form of arthritis. It affects about 1 in 25 adults in Aotearoa, New Zealand. It's more common in men, and it basically usually initially presents as these acute episodes of very severe joint pain. And here we can see a patient with acute gout with very severe inflammation of the big toe and also the ankle here. And this person would be unable to walk, they'd be unable to really even have their sheet on the bed because of this very severe pain. In some people who have prolonged elevations of the urate level, tophaceous gout occurs. And this is the disease that we've been particularly interested in and focusing on in our research. So here we have these large swellings of the joint, which are collections of uric acid crystals, and these crystals essentially cause joint damage and a lot of deformity, difficulty finding shoes. They can discharge, ulcerate, and really they cause a lot of problems for people with gout. So in order to achieve effective treatment of gout, the key target is to get the uric acid level down. And if we do this, the crystals dissolve, the gout attacks settle down, the tophi, these big lumps, they get smaller. So this is really the key focus of our treatment, is to get the blood uric acid level down. And the way we do this most often is with a medicine called allopurinol. And this is really the first line treatment for people with gout. To get the uric acid level down. It's incredibly cheap, costs about $10 a year as far as the prescription for people. The important thing is that patients need to take it every single day. But it's a very effective medicine when used properly. So great, we've got a treatment. It's been around for 60 years. It's a cheap drug, fantastic, should be no problem at all. Gout, why would gout be a problem? Well, it clearly is, because if we look at data from New Zealand, if we look at data really anywhere in the world, we see that gout is routinely poorly treated everywhere in the world, pretty much. And certainly in New Zealand, that is the case. So if we look at New Zealanders with gout, a pretty conservative estimate is that 40% of New Zealanders with gout get regular allopurinol prescriptions. It may well actually be even lower. Because of this, less than a quarter of people with gout actually achieve the target uric acid levels. So really we're not managing this disease at all well within the community. And really a lot of this work has come out of, or a lot of this understanding has come out of work with the Ministry of Health through the Atlas of Healthcare Variation. We have this beautiful site on their website. I'd recommend, if you're interested, to go and actually have a look at the site. You can actually look at data, look at different regions of New Zealand, and look at who's getting allopurinol, who isn't getting allopurinol. Really beautiful website, actually. And I think this very clearly shows that areas such as counties Manukau, the East Coast, Northland, where there's a lot of gout, not much allopurinol being prescribed. So why is gout so poorly managed? I think there are a number of things that drive this, and we've started to get a concept of this through some of the qualitative work that we've done. I think it's very clear that within the community, people see gout as a disease that's self-inflicted, that people bring on because of their personal indiscretions. They've eaten too much, they drank too much, it's all their own fault. What do they expect? Of course they've got gout. There's also a belief that gout is an acute illness. It's not a chronic disease of crystal deposition. So you get the attack, you treat it, it goes away, it's not a problem. Whereas in fact, the crystals continue to form. I think this really leads to a lack of understanding about the role of urate lowering therapy. There's a lot of fear in the community about allopurinol side effects, and there's also a general kind of nihilism about actually whether patients will even take their medicine, and if they do, how effective that's going to be. The other thing that also becomes very clear is that everyone thinks gout is really hilarious. Okay, and this is just an example. This is a headline from last year in The Independent. For those of you who can't read it, North Korea news that Kim Jong-un has gout is no laughing matter. He does have a nuclear arsenal, remember. With that in mind, I say, get well soon, Mr. Kim. So again, gout as the butt of everyone's joke. It's a funny condition. It doesn't really need to be taken seriously. But when we hear the patient's experience, I think we really start to understand that actually this is a serious condition. It really impacts enormously on people's life. It has an impact on the way that they can function within families, their ability to work, their quality of life. And this is work that came out of a qualitative study done by Karen Lindsay many years ago now when she was a rheumatology fellow. And I think the study was really key to really galvanizing us to understand the impact of disease. And I'm just going to read this because this is one of the patient's experience. Well, when I get it, there's a lot of throbbing in the area. It feels like the area that's inflamed, it's cooking, it's hot, a real hot sensation. It feels like the flesh is trying to rip your outside, like it's going to burst. Your skin is stretching and it's going to rip because it's stretching so much. So really a very unpleasant experience. And really it was with these stories, these patient stories, that I think really galvanized many of us to really think about different strategies for how to actually manage gout. And this work really led to establishment of the Māori Gout Action Group, which is a collection of people who I've listed, some of the people here, doctors, healthcare workers, other healthcare workers, people from Arthritis New Zealand, Māori health workers, really a variety of people in both primary, secondary care, public health who have come together really to think about how we can address this issue. And I'd really like to acknowledge this group because I think this group has been really very important in, first of all, guiding the research we do, but also the advocacy within the community in the last 10 years. So as part of this group, the Māori Gout Action Group put together a gout responsiveness plan. And within that plan was research. And this is really the area that I have really contributed most to. Peter Gow, Arthritis New Zealand, many other people have done a lot of work with patient resource development, community clinics, strategic partners, particularly partnering with Arthritis New Zealand, who've been very strong supporters of this work, and really a focus on destigmatisation. So one of the advantages of being involved in the Māori Gout Action Group is we get to go to these lovely hui, and here I'm showing you some images from a hui that we went to in Tokomaru Bay in 2001, and certainly a really beautiful site. Just to really introduce this quote, which is, "The people of the Pacific belong to one large gouty family." And this is a quote from Kellgren, who's really one of the godfathers of rheumatology, really recognising something that we haven't really quantified to any great extent until very recently. So we really started to do this probably about 7 or 8 years ago now, and this is work that Doon Wynnard from Counties Manukau really led, really trying to get a handle on the impact and prevalence of gout in Aotearoa New Zealand. So what I'm going to show you here are the data for men, and these are the data from 2009. And this is from the Aotearoa New Zealand Health Tracker. So this is basically everyone in New Zealand who has a National Health Index number is included in this data set. So most of us are included in this data set. And so basically what we did was using some algorithms to identify people with gout, identified those, the prevalence in those at various ages. So here we have 20 to 24, increasing up to 85 years. Here we have a prevalence of 0% and up here 50%. The purple shows the overall prevalence for the entire country. So you can see that as we age, it's more likely that we'll develop or have gout. If we then look at the ethnicity data, I think there's a very clear pattern here, and this is something that we'd all seen in our clinics but perhaps hadn't really quantified to any great extent. So if we look here in the light blue, we can see New Zealand European, in red New Zealand Asian, in dark blue Māori, and in green Pacific. And I think you can see that really at every age, Māori and Pacific men are affected by gout about 3 times as often as other populations in New Zealand. So certainly a very important burden of disease. If we look at women, gout affects women less frequently, affects women more after the menopause, but again these differences in ethnicity, so much more common in Māori and Pacific women compared to women of other ethnicities in New Zealand. We've also done quite a lot of work trying to understand the impact of disease for individuals with gout. So this is work that we did many years ago. In fact, Kate Gregory, who was my first summer student, who's now a rheumatology registrar, actually did this project. This was her summer studentship many years ago now. And this was a study where we study men with, or patients with gout came in, and we just basically assessed their hand function. And what was very clear was that those patients who had tophi had major problems with their grip. They had difficulty really with just very simple tasks that all of us just take for granted. More recently, we've done similar work led by Keith Rome at AUT, looking at the impact of gout on foot function. And of course, gout most often affects the foot. And again, we can see really marked differences in gait and many gait parameters related to having gout and urate crystal deposition. In addition, we've now developed a questionnaire, and I think this is a really fabulous questionnaire for a couple of reasons. Opatai Ati, who worked with me for many years, who's now a medical student, did his master's and really developed this questionnaire, and it's hosted on the faculty website. So it's really we've had a lot of support from the faculty to get this questionnaire actually up and running. So I think that's a really great achievement as well. In addition to understanding the impact, we've also really focused a lot on defining the mechanisms of gout, understanding that this is a disease of chronic uric acid deposition, and here we see some dual energy CT scans of patients who have no clinically active gout. These are not people who are coming in saying, I've got a sore foot at the moment. They're people who've had disease previously, but we can see on these scans these uric acid crystals colour-coded in green throughout the joint. So even when patients aren't flaring, even when they're not saying, oh, my foot hurts, the crystals are still there. And we can really see this beautifully on the imaging methods. We've also spent a lot of time trying to understand the mechanisms of hyperuricemia, and this is work that we've done in collaboration with Tony Merriman at Otago, funded by several HRC program grants now, really trying to understand the genetics of this disease, which is clearly quite different in Māori and Pacific people compared with New Zealand, European or other populations. We've identified certain genes that are very strongly associated with gout in Māori and Pacific people. We've actually identified just hot off the press, the first specific gene for Māori and Pacific people. And it's very interesting that pretty much all of the genes that we've identified as being important are related to the way that the kidney handles uric acid. So this is a very different concept of gout as a disease of dietary excess. This is really gout as a disease of kidney dysfunction, of the way that our kidneys handle uric acid. Of course, diet is important, and work that we've done with the genetics of gout in Aotearoa study has shown this, and this is just some data looking at sugary drinks and showing that for those people who are drinking a lot of sugary drinks, the likelihood of having gout is much higher. But again, data from our group has shown that there are genetic factors that interact with sugar-sweetened drinks to increase the risk for some people and not for others. So this is a very complex interaction. It's not just about people doing the wrong thing. And the work that I've really primarily focused on in the lab, and also with the imaging group as well, has been understanding joint damage in people with gout. And this is these are just some of the images from our study where we've looked at urate crystal deposition and the relationship between urate crystal deposition, here colour-coded in green, and these typical areas of joint damage in people with gout. So clearly crystals are driving a lot of the joint damage that we're seeing in people with gout. The lab work has focused on bone, but also on cartilage and tendon as well. And I've stolen here a beautiful diagram from Ashika Chana. And so I do apologise for that, Ash, but I think this really summarises the work that we've done, particularly Ash has led in the last few years, really trying to understand the mechanisms of disease in cartilage, in bone, and also in tendon. And for each of these sites, we see crystals really having a marked effect on the tissues around them, causing damage and structural problems at each of these sites. And finally, of course, treatment, because ultimately we really want to use these data to improve outcomes for patients. So I'll just remind you again of this really important target, which is getting the serum urate below 0.36. And one of the first studies that we did many years ago now in Counties Manukau DHB with Peter Gow and Sunil Kumar was looking at allopurinol dosing. And in those days, we were very conservative with our allopurinol dosing. So we would give tiny doses of allopurinol to people with kidney disease. And then we would just say, oh dear, allopurinol hasn't worked. What a shame, we don't have any other options, because in those days we really didn't have a lot of other options. And the work that we did there demonstrated that actually most of the people who were on these very small doses of allopurinol weren't getting anywhere near their serum urate target. But if the dose was increased, then a lot more patients were achieving this target. And this has then led on to a number of studies led by Lisa Stamp, who's again another really sort of key collaborator for me, who Lisa initially did some dose escalation studies and open label studies and showed that this approach was very well tolerated, very effective, up almost 90% of people actually achieving target. And we're just in the process of completing a randomised controlled trial specifically looking at this, and this will be reported early next year. One of the really exciting possibilities for me, having studied joint damage in gout for many years, is that joint damage itself may be reversible. We don't have a lot of data to show that, but we do have some data from a small study of patients who had very, very intensive urate lowering therapy. These were patients that I collaborated with in the US. 2 years after this very intensive treatment, we can see the bone erosion that was present at baseline is healing very nicely, and certainly major improvements in the erosion score, perhaps not so much in cartilage, but I think it's certainly possible that with very intensive urate lowering therapy, we may be able to achieve healing of some of this joint damage. Of course, ultimately, it would be better to avoid that. We also have a whole lot of therapies that are going to be coming to market. So this is a very exciting field. We've been involved in clinical trials and clinical trial development of a number of these agents. So I think this is really a very exciting time. You know, for almost 60 years, we've had allopurinol as our main treatment, and now we're seeing more and more treatments becoming available. So certainly really great. It's not all about the drugs, unfortunately. Well, it's not all about the drugs. Other factors are important as well. So care of the feet is also very important for people who have very severe gout, and this is again a clinical trial led by Keith Rome, demonstrating that patients who receive good footwear can have improvements in their pain and disability, and this is something that we really need to advocate for our patients. And also looking at dietary strategies, and this is just one of the studies that we did with Fonterra a number of years ago, looking at various milk products for treatment of gout, and certainly milk products do allow patients to achieve a mild reduction in uric acid levels, but this is really nowhere near where they need to be. So this is an adjunct rather than the mainstay of treatment. So one of the things that we've really worked hard on, particularly within the Māori Gout Action Group, is trying to apply these findings of research into improved outcomes for patients. And I'd really like to acknowledge Susan Reid here, because who's in fact in the audience, who's a health literacy expert who's really done some amazing work, really translating some of these findings and these concepts into resources for patients and for practitioners actually to improve outcomes for people with gout. And I'd really recommend this lovely little handout for those of you who are seeing people with gout in your clinics, for example. This is the one to be using. We've also had a bit of an offensive on really dissemination, so lots of local dissemination, BPAC guidelines. We've introduced the Gout Symposium as the main teaching for our undergraduate program for the formal teaching, so all medical students now hear about gout as part of the program, and hopefully get the right messages about gout management. We've developed clinical pathways within primary care, and I think one of the really exciting things has been the application of the genetics research and the research more generally about the impact of disease into actually advocacy for patients. So I mentioned before this SLC2A9, which is a gene that is very important for the cause of gout in people with, particularly Māori and Pacific people. SLC2A9 is targeted by a specific drug called benzbromarone, and this was part of the application that we actually made to Pharmac to get this drug funded. And Pharmac really amazingly funded this drug on Section 29, so not even approved by MedSafe, but basically funded this drug because they saw this was such high need based on the advocacy from the Māori Gout Action Group. And again, for buxostat, another new drug that reduces the uric acid levels. MedSafe expedited approval because of high need, and again, this was supported by the Māori Gout Action Group. So, this is a group who really has been doing this in, doing other jobs and really doing this part-time, but a group of people who've come together, really fantastic advocacy and coordination, I have to say. So I think research has been really important in improving the outcomes for people with gout. I think it's helped us to define the problem, which is really important when we're looking at advocacy, advocating for therapies. I think it's been really important for awareness raising, for destigmatization, advocacy for targeted drug therapies, and also opportunities for education as we recruit within the community as well. So, I think that research is not separate to practice. Actually, research can really lead to improved care for individuals and also for the wider community as well. So where are we heading? Well, I hope we're heading towards a better future for people with gout. I think we really are starting to see a change in the perception of disease, gout as a treatable form of arthritis, as a chronic disease of urate crystal deposition. I think we've really worked hard at dispelling the myths that this is all about diet, and really targeting on the serum urate level. I think this is hopefully, and I hope, well, at least I hope we will see earlier use of urate lowering therapy, better use of old drugs, and I think allopurinol will remain the main treatment, and we just need to be using it a lot better, but also combinations of old and new therapies. And ultimately, I hope we will not be seeing these crystals anymore, and we will be seeing patients who are achieving target, who have fewer prescriptions for anti-inflammatory drugs, which are very toxic, who have less joint damage, less tophaceous disease, less time off work, more participation, and less disability. So I'd just like to finish with some acknowledgements. First of all, I'd really like to acknowledge the many patients who have contributed to our research projects. We've recruited thousands of patients in Auckland over the last 10 years, and really we've had amazing support from patients. We've had really wonderful funding support from HRC, AMRF, lotteries, the university through the faculty funds, Lacta Pharma, and also the Auckland Regional Rheumatology Trust. There are many people who work on these projects, and I have tried to list everyone here. I do apologise if I've missed anyone. I'd certainly like to acknowledge Brigina Poole, who's really a key person in the lab, and Ashika Chana, and the other members of the Bone Research Group, who are just really fantastic colleagues and incredibly professional. The guys who have been doing the recruitment over the years, Opataya, Paul, Julie, Chris, Jordan, Megan, Anne Horn, who just runs a really amazing unit. The members of the Auckland Rheumatology Imaging Group, particularly Anthony Doyle, who really has scored so many CTs and MRIs over the years, so it's really been wonderful. the many other collaborators, my colleagues at ADHB, Maria Lobo, Megan Williams, Ravi Supaya, Julia Martin, who are just a really lovely group of people to work with. I've already mentioned the Māori Gout Action Group. And I'd just like to finish by acknowledging several of my mentors and people who have really been incredibly supportive. Jill and Ian, who welcomed me into their group when really they didn't know who the hell I was, and really were incredibly supportive and have really just made it's so easy to actually get going, which was really wonderful. Fiona McQueen, who unfortunately can't be here, who again has been really an amazing mentor and support for many years. And also Peter Gow, who unfortunately is ill. But again, Peter has been really a stalwart of gout management, has been working on gout in Auckland for a good 30 years. And I think really, I can't say enough about Peter. I'd just also like to finish by acknowledging my family, my parents, who have been an incredible support and just wonderful for many years. The rest of my family, many of whom are here today. And finally, I'd like to acknowledge my kids, Maisie and Henry, and also my wonderful husband, Andrew, who really just makes the whole enterprise kind of work and is just an amazing person. So thank you.
I'm Philippa Poole. I'm the head of the Department of Medicine and acting head of the School of Medicine. And thank you all from the school for coming along to this really important and special occasion, not only for Nicola, but for us all in the school and the faculty. And thank you to the family for letting us have so much of Nicola too. We're really lucky. I think you'll agree that we've really seen a masterful lecture tonight that's taken us from basic science through clinical science, clinical observation, and then to the research lab, and then translating it back into the community. And you know, that's a really rare kind of set of skills, and really shows, I think, the importance of having clinical academics in this faculty and what they can bring. And Peter Gow did want me to say, you know, how much Nicola's work has actually contributed to the health and well-being of the communities in South Auckland, and obviously further around the world now as her work becomes more well-known. Now, there is an old Māori proverb, ka ore te kumara e korero mō tōna ake reka. Probably shouldn't mention sweet in this context, but anyway, the kumara never speaks of its own sweetness. And I think, you know, I'd really want to say to Nicola, you know, apart from all this amazing research, you're just the most wonderful colleague, thank you. And your serenity and professionalism just never fail to amaze me. You know, always take on extra work, you teach, you lead, you conduct all this research. And, you know, really haven't missed a beat since you came to join the faculty in 2005 properly. And as one of her, Ash, one of her students said to me, things often don't go to plan in the lab, but Nicola manages to see the bright side and helps make me see that there's always something to learn from failed experiments. She also taught me how to have research integrity, how to do things properly and honestly. She has very high morals and ensures that we only publish or present results of the very highest quality. So I echo Ian's words, in a very short academic career, Nicola, you've already achieved so much. We're so proud to have you in our midst and as our newest professor. Please join me in thanking Nicola for her lecture.
For those nice words, and I should also like to echo my own sentiments that Nicola has been one of the more meteoric risers within the faculty, and she is very young, and I expect we'll see many more years of quality research and quality medicine from you. So congratulations again, welcome to the professoriate, and thank you all for coming tonight. And just to remind you that our seventh and last inaugural lecture is Professor Sally Merry, and that will be on Thursday night, so I hope you can attend then. Thank you for coming. Good night.